Thank you, dear moderator, for the introduction. Dear colleagues, we'll talk about prostate MRI interpretation in the next 30 minutes. I have nothing to disclose. Prostate cancer MRI stands for multi-parametric MRI of the prostate, which includes T2-weight imaging, providing information about anatomy, diffusion-weight imaging, providing information about the biology of the prostate cancer, and vascularity provided by the DCE. So T2-weight imaging is a cornerstone of imaging in prostate cancer. You can actually appreciate the peripheral zone, which has a higher signal intensity compared to the transition zone, which is located over here. And if you look at the T2-weight imaging, in this case, there's a large bulky lesion in the left peripheral zone. However, not every low intensity area corresponds to prostate cancer. So also other benign diseases may mimic cancer, like prostatitis, BPH, or even biopsy hematoma. So we have to add other techniques to improve the accuracy of MRI of the prostate. For example, adding diffuse-weight imaging, which provides information about the biology. Vascularity, a lot of things will enhance after contrast injection. However, not every enhancing nodule of lesion will present prostate cancer. Especially in the transition zone, it's quite cumbersome to use DCE and detect cancers. For example, in this case, a lot of enhancement is visible in the transition zone. However, most likely this will be BPH if you look at the T2-weight imaging. So far, a lot of imaging techniques are being used. I didn't mention, for example, MR spectroscopy, and there's a need for standardization. So that, for example, we talk the same language in Italy, Netherlands, and, for example, Japan, to acquire the same imaging sequences, and also if we make a report that we make the same conclusion at the end of the day. The first attempt to do this was by the PI-RADS version 1, which was introduced in 2012. We introduced the PI-RADS version 1 based on guidelines how to acquire the images, but also how to interpret the MRI images. We got a large list of how to interpret, for example, T2, diffusion-weight imaging, and also perfusion imaging, and you could score points for each sequence. However, there are some limitations with regard to PI-RADS version 1. There's a rapid progress in the field, so there are increasing numbers, for example, in terms of MR sequences. Diffusion-weight imaging is increasing, for example, in resolution, but also different kind of post-processing techniques are available to look at, for example, diffusion-weight imaging. Furthermore, because we had a lot of points which could be scored on T2, diffusion, and perfusion, we tried to simplify the interpretation, and also this will most likely simplify the widespread adoption of this technique. And also want to have a single international standard for prostate MRI. So in version 2, which was introduced in 2015, already 2 years ago now, we also looked, if you compare version 1 and version 2, the focus in version 1 was technique, detection of significant cancers, the clinical applications. We also included extraprostatic extension and staging in PI-RADS version 1. In version 2, we had a more globally involvement of the ACR, ESUR, and ADMITEC Foundation, and the focus was lesion detection and characterization, but also including benign diseases compared to the version 1. It also included explicit instruction how to interpret, but also how to measure lesions within the prostate. And for example, images were provided how to look and to score certain lesions on the T2 diffusion and perfusion maps. A lexicon was provided and even an atlas, for example, which location within the prostate a lesion would be assigned to. There's a huge debate what is clinically significant cancer. In the PI-RADS version 2, we focus on Gleason score 7, including a 3+4 with prominent but not predominant Gleason 4 component. That's, I think, already a discussion. A volume of 0.5 cc or extraprostatic extension. And for each sequence, at the end of the day, we have the assessment categories, and each lesion is assigned a PI-RADS assessment category on a 5-point scale for T2 and diffusion, and for the perfusion, it's either positive or negative. And if you score the entire lesion, it's either 1 to 5, 1 represents very low or low chance of finding a clinical significant cancer, and if you have PI-RADS 4 or 5, the presence of a significant cancer is high or very highly likely to be present in that particular lesion. In PI-RADS version 1, the highest B value was 1000. We advise to use at least a B value of 1400 or even higher, and may be acquired depending on your system, or being calculated if you have the possibility to extrapolate your extrapolation on your diffusion weighted sequence. For example, this is an ADC value, shows impeded diffusion in the transition zone on the right side. The calculated B value shows the high signal intensity, which corresponds to the impeded diffusion area. But if you go to a much higher B value of 2000 in this case, which is also calculated, this is more likely to catch your eye and look, for example, at the T2 to make your final diagnosis. Version 1, we had also a 5-point scale for DCE. It's quite cumbersome, and it was comparable, for example, with the breast MRI interpretation. We tried to simplify that, for example, by it's either positive or negative, and a positive finding was if you have a focal and early enhancement of a lesion which was seen either on T2 or diffusion. I will show an image in one of my next slides. What about MR spectroscopy? In PI-RADS version 1 we included MR spectroscopy, but in version 2 we didn't incorporate it. It's not discussed in the document, and cannot also be incorporated into the overall score. And just to stress that PI-RADS version 2 is only focusing on detecting cancers. So if a patient has a biopsy-proven prostate cancer, or a patient comes in for a local recurrence question, we don't use the PI-RADS version. In PI-RADS version 2 we also have a dominant sequence. So for the peripheral zone, the diffusion with imaging sequence is the dominant sequence. In the transition zone, the T2, because we have a lot of false positive if you only look at the high B value compared to T2 with imaging alone, and DCE plays a minor role. So we have simple algorithms and tables to determine the overall score, the assessment category. Some examples. I won't go into in too much detail, but for T2 we divide the prostate in the peripheral zone and the transition zone. And if you look at, for example, in this case, this is a PI-RADS 1 normal peripheral zone. We don't see any abnormalities. However, if you look closely, there's an abnormality visible here in the transition zone, most likely a large cancer. Again, peripheral zone, some heterogeneous, mild hyperintense lesion with an indistinct margin, for example, on this side, in the right peripheral zone. This triangular-shaped lesion, most likely atrophy or post-biopsy artifact, quite often seen, and this most likely will be some prostatitis. Another example, small homogeneous mass in the right peripheral zone. This most likely corresponds to PI-RADS 4 on T2. And the transition zone, those lesions are very difficult. Look at, for example, this case on the left-hand side, bulky BPH nodules within the transition zone, very difficult to interpret. A lot of false positive findings are found in this area. And also, if we get referrals from outside, a lot of those lesions, like for example these lesions, are overcalled for cancer. So if it's a nodule within a nodule, you can be quite sure that this is not a cancer. The same is true, for example, for this lesion. It's still within a BPH nodule. The capsule here is intact, so there's no invasion through the capsule, so most likely this is a benign disease, so BPH nodule. This is an example of a 5 lesion, more than 1.5 cm. This is a large bulky lesion with also invasion into the anterior fibromuscular stroma, quite often this area is overcold for cancer, but in this case, this is moderate hyperintense and not as dark, for example, as this area, which can correspond to anterior muscular stroma. Diffusion, we don't make any difference between the zones, so if it's either in the peripheral zone, transition zone, or central zone, we will use the same scoring system for diffusion. As an example of no abnormality, we're aware there's always some abnormality at the mid-level or at the base of the prostate. The triangular shape, be careful, these are the ejaculatory ducts, which also is a pitfall for assigning that as a cancer. There's a small lesion visible here in the right peripheral zone, less than 1.5 cm on the actual image. It's a PI-RADS lesion, and with a high B value, shows a high signal intensity. DCE, as mentioned before, has a minor role in PI-RADS version 2. We only look at focal and early enhancement. And if you look down at, for example, this case, with a PI-RADS 1 to 5 score, we only look at the peripheral zone or the transition zone. And in the peripheral zone, the diffusion with imaging is the most dominant sequence. So only if you have a score of 3, if it's equivocal, the DCE can alter the final diagnosis and upstage a PI-RADS 3 to a PI-RADS 4 lesion. For the transition zone, the T2 is a dominant sequence. And if you have a score of 3, the diffusion with imaging, only if it's a score of 5, can upstage the lesion within the transition zone T2 from a PI-RADS 3 to a PI-RADS 4 lesion. So I have a case here. PSA of 6, 1 negative thrust biopsy session in the history, very small prostate, but the PSA density is above 0.15. So there's a chance of finding a clinical significant cancer. It's a T2 sagittal and axial, and if you look at it closely, the entire peripheral zone look mildly hyperintense. If you look at the diffusion, there's some impeded diffusion in this area, somewhat high signal intensity, but I'm not really convinced. And if you look at the PI-RADS category for T2, the first question is where is it located? I already gave that away. It's a peripheral zone lesion in this area. So it's most likely at the apex mid part, so in this area, corresponding area, there is the lesion located. So in the peripheral zone, and so the score for T2, in this case, is T2, diffuse mild and hyperintensity. Most likely, if you would see this case the first time, I would think about prostatitis or chronic prostatitis. However, the diffusion, there's somewhat high signal intensity and a high B value, but not very, but there's no impeded diffusion. And based on the criteria, you call this as a category 3. So if you come down to the peripheral zone lesion, diffusion score of 3, only the perfusion may alter the final diagnosis. So with a dynamic contrast MRI was performed. So it's either no early enhancement or yes, focal early enhancement. So look at the enhancement curves. We don't look at the K-trans models anymore, K-trans or KP or washout. The early phase of the contrast uptake, that's the most important part in the PI-RADS evaluation. There is early enhancement, focal enhancement, at the same location as the abnormality seen on the high B value. So most likely we'll call this positive. So there's focal enhancement. So the final score in this case is PI-RADS 4. So what we do with those lesions, PI-RADS 4 or 5, we most likely will do a target biopsy, either in-bore or trust-MRI fusion biopsy. And if you compare in this meta-analysis from Moon 2014, what is the sensitivity and specificity for PI-RADS? PI-RADS version 1, the sensitivity was around 75%, an increase in PI-RADS version 2 using a dominant sequence up to 82%, but still there's some room for improvement. And PI-RADS, of course, is not the holy grail, because if you look at the inter-observer agreement between expert readers, this paper from Andy Rosenkrantz in 2016, it is fair to model the inter-observer agreement. So the idea behind PI-RADS was standardization to get people doing the same sequences, minimal requirements, minimal image quality, but still there's room for improvement, how to interpret and how to perform the analysis of the prostate MRI. So despite the improvements, the precise details of the scoring system reflect a combination of the most relevant published data, supplemented by the experience of the developers of the system. So we need studies to validate the system and to highlight potential continuous limitations. So what are the improvements or suggestions for improvements? Especially the transition zone is quite a difficult area for us as radiologists, and we have to improve our detection rate in that area. We also could think about quantification of ADC maps or ADC values. What about DCE? A lot of discussion is going on if we should use DCE in the detection of prostate cancer. And what about active surveillance, recurrence, and focal therapy? Should we use PI-RADS for those indications? So if we dive into the transition zone, T2 again is dominant sequence, and quite often we call a lesion in TZ a PI-RADS 3 lesion because there's quite some overlap between PPH and prostate cancer. So there's some subjectivity on the hypo and hyperintense signal intensity. So signal abnormalities may vary depending on detecting parameters, and also, for example, using which B values, but also which diffusion weight sequence, and for example, also which vendor. So we have to define explicit criteria for distinguishing the degree of any such signal abnormality in the transition zone. An example, 1400 is advised as the highest B value, acquired or calculated. There is some evidence if you go to a high B value up to, for example, 3000, you have a higher lesion detection, especially in the transition zone, using these kind of high B values. What about the lesion in the transition zone / anterior fibrinosus stroma? DC has little effect on the assessment of TZ, actually no effect. A lot of hypervascularity is seen in the PPH. The AFS is hypovascular, but however, DCE may be helpful to distinguishing lesions in this area. This is an example. This is the anterior fibrinosus stroma, which is located over here, but there's an asymmetry visible in the right side of the anterior horn, and also the TZ on this side here. And if you look at the high B value, this high signal intensity on high B value and impeded diffusion, but the perfusion really helps you to assess the total extent of the lesion, which is also invading into the anterior fibrinosus stroma. Quantification of ADC. Several papers have shown that there's a negative correlation between the Gleason grade and the ADC value. So the lower the ADC value, the most likely you will have a more aggressive cancer within this certain region of interest. However, using thresholds is not indicated in the PI-RADS version 2. It also depends on the vendor, sequence dependent, B-value regime. What about the correlation with pathology? There's some interpatient variability and also intrapatient variability using diffusion-based imaging. So we can also use advanced models like IVM, kurtosis imaging. As we heard yesterday, there are some papers which shows clear benefit of using these advanced modeling, but also there are also papers against it, which shows none advantage of using these advanced quantification models. So we don't have the answer yet, but I think we have to head in this direction to have a more precise quantification, but also a more precise definition of what is a significant lesion within the prostate. Biparametric MRI of the prostate, DCE. There's a lot of discussions mentioned before. If you look at the 5 arguments against DCE, it doesn't provide significant diagnostic gain, and therefore we shouldn't use it. Extra costs. We had this morning in the plenary session about the risk of injection of gadolinium, the increase of duration of the examination, make it also less accessible. And also the role of DCE in PI-RADS version 2 is limited to the peripheral zone. So what exactly constitutes early enhancement, and enhancement that's focal and that matches an abnormality on other sequences is unclear. So we have to have more rigorous definitions of what's positive and negative. So DC is a secondary sequence, so we only upgrade 3 to 4 based on DCE, and which also may create false positives in this case. As mentioned before, this looks more like a prostatitis than a significant cancer. In this case, at biopsy, we found a prostatitis. However, we have to keep in mind we only look at detection, and if we have debates on conferences, most commonly those are the experts. And if you're starting with prostate MRI, this quite some steep learning curve. But also, if you have information, try to get all the information you have. PI-RADS is only for detection. We have also other indications like recurrences, and contrast-enhanced MRI really helps you to define and to localize the recurrence within the prostate. But what about active surveillance? Most oftenly, the diffusion with imaging will not help you in finding the not significant lesions within the prostate. Of course, it will help you if the Gleason goes from a 6 to a more aggressive one. But basically, the DCE will help you to define and to localize the lesion within the prostate. What about focal therapy? Diffusion with imaging after focal therapy is quite difficult. How to interpret and what's the value of diffusion is still not yet known. Also, artifacts, if you have gas and rectum, hip implants, may also degrade the image quality. So we have to think about smart algorithms. For example, we just do T2 diffusion, and in some cases in which we have technical difficulties with the diffusion, but also if you have degraded image quality or patient move of rectal gas, you may call the patient back and then inject contrast, which is of course less expensive than giving contrast to each patient. What about active surveillance currents and focal therapy? I already mentioned that. I think PI-RADS has to be adjusted for other indications. Recurrence T2 is less important. DC and diffusion is more important. If you have a lesion in a transition zone, after, for example, radiotherapy, DC and diffusion is much more helpful than T2. And with active surveillance, we focus on non-significant disease, as mentioned before. So what are the challenges? What about the size? 50 millimeters is just based on expert opinion. Of course, we have some evidence, but the question is, should we downgrade, for example, to 10 millimeters? In the PI-RADS version 2 assessment, we don't take into account clinical scenarios. What should we do with the PI-RADS 3 lesion or 4 lesion? Which one should we biopsy? Which one should we do a follow-up? And we also should use our brain at the end of the day, because only a PI-RADS score doesn't give you the final conclusion. You also have to include all clinical data from the patient, like PSA, digital rectal examination. Is there a fast increase in PSA? What about PSA density? PSA kinetics, which will influence the conclusion in your report. So what do I recommend? In PI-RADS 1 and 2 lesion, we don't do a biopsy. In the PI-RADS 2, follow-up depends on the lesion. For example, if it's a BPH, we don't suggest follow-up. Based on recent literature, we found that if you have a PSA density below 0.15 and a PI-RADS 3 lesion, the chance of finding significant cancer on biopsy is very low. So we don't recommend biopsy in those patients. To PSA density above 0.20, we advise to do MR target biopsy. In 20% of the case, you'll find a significant cancer. And 4 or 5, we advise to do an MR target biopsy, either IMBO or using a truss MR fusion. So in conclusion, there are several challenges. We already have made some good steps in a good direction. However, the interpretation, there's still quite some inter-observer variability in interpreting prostate MRI. Of course, if it would be very easy, we wouldn't be here. But it took us at least 15 years to get here. So if it would be easy, then we already had the solution. Furthermore, we need validation studies. For example, we look at outcome. There's a lot about validation, but also outcome studies are needed. So what is, for example, the implication on outcome, for example, for PI-RADS 4 or 5 lesion for the patient? And we have a lot of expertise, evidence. If you look at studies, there are a limited number of studies done in a multi-center setting, multi-vendor setting. There are hardly any studies done yet. Prospective trials are not there yet. Of course, single-center studies are there, but we need more evidence with regard to multi-center and multi-vendor studies. And this information will provide improved recommendations in the future. Thank you for your attention.